Good evening, everyone. Thank you for joining our Men's Health webinar. I'm Preston Brickner. I'll be your host and moderator. Just to start off, we got a couple quick housekeeping items, then I'll turn it over to our speaker. First, your attendance tonight is completely anonymous to all the other attendees. No one can see your face nor your name, and any comments or questions will only be seen by myself and Dr. Natale. If you wish to ask a question, please type it in the chat box. It's at the lower part of your screen. We'll do our best to include as many of them in the Q&A session after the presentation has concluded. Our presentation tonight should last approximately 1 hour and will be presented by Dr. Richard Natale. Dr. Natale was born and raised in Southern California, and as the son and nephew of physicians, he knew from a very young age that he too would pursue a career in medicine. He attended the University of Southern California, where he graduated with honors with a bachelor's degree in biological sciences. Given the opportunity to attend his father's alma mater, he went to medical school at the University of Louisville School of Medicine in Kentucky, graduating in 2004. Dr. Natale completed his urology residency training at the University of Florida in 2009. He chose to practice medicine in North Carolina for its natural beauty, friendly people, and unique medical community. Although Dr. Natale's expertise covers a broad range of urological conditions, he has a special interest in men's health. This area of urology includes treatment of common conditions such as erectile dysfunction, urinary incontinence, Peyronie's disease, low testosterone, and enlarged prostate, or BPH. Dr. Natale, thank you for your time tonight. Go ahead and take it away, sir.
All right. Thank you, Preston, for that introduction, everybody. Good evening, and thank you for joining the webinar. Happy Halloween ahead of time for anybody who might be trick-or-treating tonight or tomorrow night. I think most of us probably give that up as a pastime, but you never know. Well, I have the honor of being able to present kind of a discussion on the risk factors, the kind of background of erectile dysfunction and the things that we can do to fix ED in patients. One of the things I would like to start off with early on in the webinar is actually two things. One, there's plenty of information online, so don't ever feel that no one needs to take notes. These webinars will be available for you later. Certainly websites like edcure.org are very comprehensive in the way they're able to kind of educate the patients and hopefully reflect a lot of what I was just talking about. So certainly that's a resource I encourage all my patients to go to. You see where you can kind of grab that QR code. So you take your phone, just hold the camera over that, and that should be able to get you to that website should you choose to do something more research on your own. After this, kind of going back into the second part of what I meant to say was, I do like to go through these slides relatively quickly because I prefer to be able to give people opportunities to ask questions. I think it's a unique chance that in a little bit of an unpressured way, we get a good discussion as to why we may be dealing with the issues we're dealing with. More importantly, in a safe environment, anonymous way, we can share experiences, questions we can all learn from. Well, with that being said, let's start off with understanding what this terminology erectile dysfunction means. We have the tendency to imagine what I like to joke as the floppy noodle, that you just don't get it up and that's it. And if it's that, well, that only happens to older guys. But if you really define it as your inability to perform to the level of which you're accustomed and or maintained throughout that whole the course of intercourse, now you're starting to see that is a much, much broader definition that holds, up to 20% of men in America today to the hostage, so to speak, right? I mean, there are men, the estimates, and I'll bet you it's actually underestimated, that there could be tens of millions of men dealing with erectile dysfunction when you really open up the definition to include anybody who has a hard time getting or maintaining. Now, the erection process helps us understand a little bit of why this can happen. And the best thing I can give you is the analogy of what, in looking at the pictures that are on the slide of this. Imagine the penis, if we were to look in the internal parts of it, is comprised of two cylindrical dish sponges. They're sitting next to each other. And imagine those dish sponges are what you bought at the grocery store. They're still in their plastic wrap. Inside the sponge, blood will flow in through arteries in that area and out of small veins that are in that plastic wrap, keeping us soft. Or when we get an erection, the blood flows into that sponge very aggressively. The tissue becomes swollen and distends, and then it traps blood inside by compressing against that plastic layer and shutting those veins down. And of course, obviously, the reverse scenario is true. Once the process of intercourse is over, that all kind of reverses itself. But you can understand that blood flow issues and then the sorts of causes of blood flow issues are tied into erections, right? So when we think about erectile dysfunction, you kind of, A, have that broad definition that we talked about, B, look at who may be most at risk. If you see that pie chart, basically that's a lot of us, right? I mean, we understand that the prevalence of diabetes, blood vessel issues, heck, even the side effects of medications can cause some of this. So when you look and you start understanding that, gosh, this is why so many men can be affected, because these are conditions that most of us will deal with in our lifetime. Certainly from my standpoint, we think about surgical interventions, for example, prostate cancer treatments, but that's just a small sliver of that pie. The rest of it is what you and I may deal with on a day in and day out basis. The big one, though, to really start talking about is diabetes, right? Because we see what the prevalence of diabetes is in the United States. Now, this is old information, but still relatively important to understand. And I'm sure those numbers will increase with time. Excuse me. But patients with diabetes, the issue at hand is that they are not only more likely to develop erectile dysfunction, but more importantly, they're more likely to develop a kind of resistance to the treatments we offer patients, and are more likely to progress on to other interventions that are required to be able to get them to have erections again. Why? Diabetes is a special condition that actually touches on both issues, meaning when I talk to folks about a general cause of erectile dysfunction, I always give the analogy, there's basically 6. Either the blood flow in is not good, the blood flow out is too much, there's a hormonal issue, there's a neurological issue like prostate cancer and surgeries, okay? There's side effects of medications, and then there's just the above the shoulders, as we call it, the psychosomatic, the part of it that makes us all stressed out. So those are the 6 causes. Well, diabetes will hit 2 of those. It'll hit blood flow issues, it'll hit nerve conduction. So that's why you see patients with diabetes who are more prone to developing these issues. It's key for understanding how we manage erectile dysfunction, because it's not just give you a pill and pat you on the back. It's also about lifestyle modifications, talking about how we can get you more compliant with your diabetic regimen, so on and so forth. There's more to what we do than, again, prescribing a pill and saying, let's be on our way, we'll be okay. Now, another important thing, this is actually important for particularly the younger guys in the crowd, which is this. A very interesting study or studies over the years have been the association of men having erectile dysfunction associated with cardiovascular disease, and having seen at least a couple of patients that presented to me as younger men with what we call primary ED, that no other symptoms, they just came in because they're having a hard time with erections. And having the opportunity to follow these guys over a decade, I've actually seen patients who came in with ED and wound up having coronary artery disease develop down the line. Basically, the answer to it is this: the penis is the canary in the coal mine. So however healthy you are, in general, your penis is reflected. So we do understand there's a risk associated with ED and coronary artery disease. We will ask the questions and keep that in mind for your future health. But it's all really tied into blood vessels. Again, the same kind of idea. Why? Well, all the way on the right side of the screen that I see, you see where it says femoral artery, and all the way on the other side, you see the penile artery. The size of blood supply to those particularly important areas of our body. Femoral artery provides blood to our leg. You see how big that is. Well, if a patient, for example, has diabetes or has high cholesterol or a family history of coronary artery disease, the things that can lead up to heart attacks and all the rest. Well, if you calcify or block up an artery the size of your leg artery, or you can do the same thing with the artery that supplies our brain, you can imagine that guys who have erectile dysfunction, plaquing or causing blockage of that artery is pretty easy. So that's something to keep in mind as well. Because again, I like the idea about canary in the coal mine. If you're dealing with ED and you don't have any of the other issues, that's the first discussion we have is let's figure out ways we can manage your overall health, because again, it could be a future predictor of coronary artery disease. Now, I told you that list of causes of ED issues, and one of them is low testosterone. Now, I don't want to directly correlate them, meaning it's not as though you have low testosterone and you must develop erectile dysfunction. What it really pertains to is more about the energy, drive, the interest. And when you look at that, if you have low testosterone, well, if you're having a hard time making it through the day at work, if you're, you can be moody, you can be tired, have poor recovery, maybe poor sleep, that's less likely going to lead to good, strong erections, right? You're going to have ED issues that come out of that simply because you just don't feel yourself. So whenever I see a patient who comes in, we'll go through these questions, and one of which will include is, maybe we need to check your testosterone levels because that could be an underlying cause as well. And of course, if we do identify that, there's plenty of treatments that are available. This isn't really for tonight, but it's good to have that available for you to understand that there are options outside of just kind of living with it, so to speak. Now, erectile dysfunction and prostate cancer, a little bit of a carve out for a second, because we talked about some of the issues related to nerve control. And while not a lot of people are in this boat, there are going to be patients, men, who've undergone treatments for prostate cancer, typically prostate removal, that develop erectile dysfunction as a result. Now, I can't overemphasize how important this picture is. And it's not because we're doing an anatomy test and you'll have to take any sort of quiz at the end of this all, but it's more to understand why you develop erectile dysfunction after a surgery like a prostate removal. Now, not to get into the weeds too much, but if you look on the bottom where it says neurovascular bundle, that's the nerve bundle that provides the sensation, that provides the signal to our penis to be able to get erect. Now, when surgeons do an operation to remove the prostate, what they'll say is, we are going to preserve the nerves if we can, which means the ones they can see well, which are the ones on the bottom. The problem is that the nerves don't just live on the bottom of the prostate. They actually wrap around on both sides. So even in the most experienced, skilled surgeon possible with perfect preservation of the nerves, problem is you're disrupting that nerve connection network. So at the very least, you may have troubles with maintaining a full erection or achieving it. But at the very most, even in the setting of what I just said, you may have ED that becomes poorly responsive to medical therapy. Doesn't mean your doctor had any other sort of mistakes that were happening. This could just be even in the best of hands. Now, other things that we see, unfortunately, prostate cancer in general and the treatments of prostate cancer, even outside of prostate removal, but also things like radiation, still can damage the erectile nerves and cause erectile dysfunction. So while there may be a more immediate effect from surgery, some studies have shown that prolonged effects of things like radiation, ED, will develop in patients as well. Now, next slide here. This is a little bit of another kind of special carve out, if you will. For those of you who are dealing with Peyronie's disease, and give me 1 second. For those of you maybe dealing with Peyronie's disease, this is scar tissue that can develop in the penis on that layer of tissue we talked about, that saran wrap that's surrounding the spongy tissue. Long story short, there's some degree of an injury that occurs, and over time that tissue gets scarred. And what it does is, imagine, kind of almost like my finger on the hose. where it deflects the water. Well, where that scar tissue develops doesn't allow the blood to fill in that area, and boom, you can get an erection. Boom, you can get a curvature as a result. Now, in addition to the curvature, we also get issues with blood flow. So you can see men who get a curvature and will start developing erectile dysfunction that accompanies it, simply because the blood flow is just not as prominent as it once was, particularly past the area where the blockage is. So, big mouthfuls of things. I think that, it's important for us to go through the kind of background information. I hope we all got that. Hopefully you'll start the questions, things, bubbling in your mind and questions you want to ask. Now I want to talk about therapies. It's important. You will hear, and most of us are inundated, whether it's direct advertisements on Facebook, in our email inboxes, if it's radio ads, TV ads, newsprint ads, TikTok ads, Instagram, whatever you want to say. We are absolutely inundated with those things that you see here. This idea of stem cell therapy, shock waves, and platelet-rich plasma therapy. The bottom line is this: there are very few studies that corroborate the actual utility of any of these. And I say that because most urologists do not offer these therapies because we don't have clinical data that supports using it in patients, with maybe the exception of the top one, the lithotripsy. But in a very in a good article, a very interesting article in the last few years, there was a study of studies. So there was a doctor that did what's called a meta-analysis, looking at all the studies performed over shockwave therapy in patients over a 10-year period of time. And in that data, they ran all these patients into one group and try to, make people as equal as they could, and then run the data again to see who could benefit or who, what the results were. And long story short, at 2 years, men under the age of 60 with no other medical problems, minimal or no chronic medications, who respond well to the oral medications but want to come off of them, when they're treated with lithotripsy, about half of them remain off their medications at 2 years. So a very small group of people are candidates for maybe some improvement with this. But for the most part, these therapies remain, as you see here, investigational. The stem cell transplants, the PRP, I think I can summarize it this way. In a study that I'm aware of out of Wake Forest about 4 years ago, perhaps a little bit later than that, they took little X-ray tags and tagged the cells and then injected them directly into the penis and looked on X-ray. Immediately within injection, 25% of the cells went completely out to the bloodstream. They never stayed put where they need to stay put. A lot of the reasons why people do those is from orthopedic data that says that it works for arthritis, but we're really not seeing all of that panning out for what we do. And you'll always hear some success stories because that's just the way it is. But right now, it remains investigational and something we don't offer our patients outside of what are known as the traditional therapeutic options. Now, we're going to go through these and I'll take a little bit of time emphasizing a couple of these, but we'll start with pills. You all know about the pills, Viagra, Cialis. What they're doing is basically allowing for the erection process to continue by kind of accelerating or preventing the loss of dilation into the blood vessels to actually get blood flow into that tissue. Pretty successful medications. Certainly the upfront, we're going to try these things first. I think every patient knows that, gee, if I could take a pill and I'm doing great, that's what I'm going to do. Certainly we got to take some cautions regarding side effects or perhaps interactions of those medications with other things. For example, patients on isosorbide, if there's anybody on that medication, you cannot have these meds because the two can actually reduce your blood pressure very, very significantly. The injection therapy, why did I jump to that next? Well, with oral medications, we know that we can maximize doses and occasionally even go as far as combining them to get you the best results. But in a patient who's failed or patients who are frustrated with that and maybe it's working okay, but really wanting to do the next step, injections can help. Now, injections also can be effective depending on how we kind of prescribe them and how they're used. You know, my biggest issue with this, and you see the side effects there, are the following. Number one is that it's a needle in your penis every time you want to have sex. Number two is if you feel like having sex on a more frequent basis, there's a cap to how much you can use this. You may only typically use it daily at most. And certainly, you know, more than once in a day really is not looked upon as a good idea. So don't like that also. But then there are a few other things. We're injecting chemicals inside of our penis to get the erections. And the problem I have with that is, particularly if you're injecting more and more of the volume or sometimes even concentration or both of the medications, you're actually scarring the penile tissue, causing something called corporal fibrosis. Additionally, if you remember what I talked about with the Peyronie's disease, you are penetrating that layer of tissue around the penis and creating one of the most common reasons for the development of Peyronie's, which is microscopic trauma and little fractures and bleeds. The reason why I bring that up is that there is an association with repetitive and chronic use of those drugs with a condition called Peyronie's, which we just talked about. So I worry about penile injections for those reasons. Certainly in people who are risk averse for surgery or other things, this is a good treatment option to go to. But my preference is, if we're talking about things, to try to find the least invasive but most effective way to treat you. Excuse me. Now, the vacuum pump, I'm not going to spend much time on outside of to understand it is a non-invasive, non-medical, non-surgical option. If y'all, and this is the point of the evening where I start being a little bit cute and tell little jokes and stories, but if y'all are anything, have spouses anything like mine, not many of us are going to be able to have the opportunity to get that contraption put on, pump it up, get erect enough, wait, and then get the job done. Most often, the interest is lost after that. Now, it does work, and in my practice, I will prescribe it in certain instances, and certainly in a man or a woman, or in a couple where intercourse is not that major of a focus, and they just want something simple. This is an option. But most often, I usually do the pills and the injections. Now, the urethral suppositories, honestly, this is there for kind of compliance and making sure that we give you all the options. This is the least likely to be prescribed in my office. Why? It's just about as effective, if at best, compared to the oral medications. When you put the little suppositories inside the penis, you see the little diagram, you're putting these little rice-like beads inside the urethra. You're dissolving that drug and allowing it to absorb in the penis to be able to give you an erection. The problem I have with that is that drug can be very irritating to the man. It can irritate the urethra, and you have to really wear a condom because it can dribble into your spouse during intercourse and irritate them as well. So a drug that doesn't work as well, has those side effects. Oh, and by the way, it's pretty darn expensive. I don't tend to prescribe. Now, the kind of last option, and I put the little air quotes on that, is a penile implant. Now, what I tell people all the time is, I don't want you going from I take a Viagra to I'm going to get surgery. But I also don't want you to think of this as, well, this is the last option. I really don't know about that. What I tell people is this, and I give them this kind of discussion. See, think about your sexuality, you and your spouse, and what you're trying to regain. If we're trying to do what we actually like to call erectile restoration, and you're trying to restore your intimate relationship with your spouse, one of the things to consider is how frequently you're having intercourse. Now, again, if oral medications work, that's great. But if you're frequently having intercourse with your spouse, it may be that, gee, I can't use the shots, or I don't want to use a vacuum, and gosh, the medications don't work. Here's our option. So again, emphasizing, it's not the last choice. It's not the last resort type thing. It is an option in the therapies that we use for erectile dysfunction. The way this works is most of them are going to be, that are implanted, are going to come a little pump in the sac that we pump up fluid. We'll have a video demonstration of it in a second. what I like about penile implants, believe it or not, is that it is the most spontaneous out of all the other options. Unlike saying to your spouse, give me a minute, I need to run to the freezer and take out the injection medication, excuse me, and I need to get it an injection. It's going to take me 15 minutes for it to kick in. This is there on demand when you want it for as long as you need it. It lasts throughout the course of intercourse. And it goes back to flaccid when you tell it to. I say that because that's why you see the satisfaction rates the way they are. And that those satisfaction rates aren't just for the patients, it's also couples. And as a matter of fact, interestingly enough, is also the answers to would you do it again? You know, well over 90% of patients saying yes to all of those. Now, the next slide shows you 3 different options of implants. The most common is that 3-piece, which again will show video. In some folks, they need to have the 2-piece prosthesis, which is a little bit simpler to operate, particularly to pump up, where essentially half of the implant towards the backside is somewhat rigid, and inside of it contains fluid. There's one small pump that's put in the sac, and you pump a couple of times to draw fluid from the back and push it into the front, you get an erection. The only reason why I don't do those only or very significant numbers is this. One, there's still not quite as natural feeling as the first option. Also, a little bit more challenging for some folks to deflate the implant. Now, the other option there, we call it malleable prosthesis, or the rods we know them as. That implant, very easy to put in, quick operation, very easy to recover from. The biggest issue with that is that essentially you are erect all the time. So you bend the penis up when you want to have intercourse, and then you push it down to your pants, or your shorts afterwards. So not a big fan of that option for patients, usually preferring to do the 3-piece prosthesis. And that's across the country. About 95% of implants are the 3-piece prosthesis. Now, the one thing that I got to tell you is when you look at the risks of surgery, which, everything has a risk, why do I choose the implants that I do choose? Not just the 3-piece implant, but more importantly, the Boston Scientific model that has something called inhibizone, which is a proprietary compound that's embedded onto all surfaces of the implant that helps prevent infection. As a matter of fact, follow-up subsequent studies have proven time and time again that the risk of surgical site infection decreases by using this inhibizone or embedded antibiotic embedded implant. So I choose that device almost exclusively because of those things. And to be quite frank with you, when you're not erect, it has a more natural appearance and feel to it, and therefore you feel more of yourself. And of course, when it pumps up, it's rigid enough to do what it's supposed to do. Believe it or not, and even the 45 years, I think we're pushing 50, these things have been around for almost 50 years. Now, the surgery back then was much different than it is now, but these things have been around for 50 years, which is pretty cool. Now I'm going to show you this video, and I'll kind of, I know we have to have some of these things here for you to understand the legalese, so to speak, but I'm going to try to speed up just a little bit. So what we're going to do here is you'll see in the implant or the 3 parts to it, you'll see the kind of patient here squeezing that pump, drawing fluid out of that reservoir that's located near the bladder area and delivering into the cylinders that are inside the penis. And at the end of it, you hit the off button and that process reverses itself. It's a simple hydraulic pump. It's about pressure differentials. The fluid moves to or from the device. That's how we get an erection. So I do like showing that. I'm going to skip ahead of that because it's a good diagram for people to see. Now, surgery itself, oops, I apologize. I'm going a little bit faster than I wanted to. But the surgery itself is, let's scooch back one more slide. Sorry. So in my hands, we can discharge patients as an outpatient. I typically keep patients overnight, honestly, for a convenience factor, one of which includes being able to give you IV antibiotics after the surgery to help reduce your risk of infection. But generally, the procedure is straightforward, under an hour. There are two ways we can do it. I do both approaches, either above or below the penis, depending on patient anatomy. Minimally invasive, we're talking about incisions that are pretty darn small, fairly easy to recover from. Certainly the one above the penis, actually a bit easier to recover from in my experience. The surgery itself may have some downtime for a few weeks where I don't want you straining and stressing. But after that, you start bringing your activities back up to more normal. And of course, it takes about a month to 6 weeks before you let you have intercourse. The treatment, the questions I get constantly is this covered? Private commercial insurers, you sometimes have issues with your employers and certain plans, but for the most part, still there is coverage. And certainly, believe it or not, Medicare covers it. So we're not too troubled about that. That kind of wraps up most of what I wanted to show and kind of discuss with y'all. Certainly here we have some nice testimonials from people that explain why they're happy with the implant. As a matter of fact, we have what we call patient advocates that are happy to reach out to you all, speak to you from a patient perspective, kind of give back some of these other things that, give credence to it, because it's not just me saying it or the company saying it, it's these folks saying it. In terms of the last kind of closing points of everything, is just to make sure that, we understand that when we get into this option, to know that these are good solutions for patients, not to shy away from a good procedure to fix a problem if that's where we need to go with that. That being said, before we completely close out the quick risks here that were there, I think I told you guys the one thing that I worry about the most, and that's a pretty low risk, is infection. We always make sure to do what we can to reduce the risk of infection. Having a bum implant or having other complications is pretty unusual. Well, that kind of wraps things up for me in terms of the formal presentation. I've already seen some questions that are coming through here. I wanted to kind of go back onto the slides, and you'll see me going kind of more mechanical here for a second, but it's more so I can get you to some information I want to have up on the screen. That being said, is there any, I'm going to start off with questions.